over all of the 10 designated line items that the American Board of Pediatrics would like you to know about. These 10 items do not include everything in pediatric rheumatology. As you may note, there is no designation for vasculitis specifically. However, I do have a slide or two in the supplemental slides that you'll receive as well. Pediatric rheumatology makes up a small percentage of what is required by the ABP, but a very important percentage. I added a shaka in the slide so you could focus on that particular line item and know that that is what the ABP is requiring of you. Let's start off with the first section, post-infectious and reactive arthritis. ABP would like you to know about post-infectious arthritis, its clinical manifestations, management, as well as specific illnesses associated with post-infectious arthritis, as well as reactive arthritis, which is actually a form of post-infectious arthritis. However, they are separating the two out. And within reactive arthritis, they want you to know about the clinical findings, as well as what you do to manage those findings. Let's move on to some definitions. So post-infectious arthritis is essentially an immune complex disease that deposits into the joint space after an infectious insult. If you were to look within the synovial fluid, you would not see any specific pathogen. Again, reactive arthritis is a specific form of post-infectious arthritis. And this starts with an infectious agent present in another part of the body, such as the GI tract, respiratory GU. I'll go into a little bit more detail in a subsequent slide. Then there's septic arthritis, where the actual pathogen is often found, however not always found, within the joint space on culture or synovial fluid analysis. As you may know, post-infectious arthritis is noted weeks after a documented illness. It's most likely a viral infection, which is why it happens in children so often. The arthritis should not have a lot of redness to the joint, erythema of the joint. It shouldn't have severe pain. No fever should be accompanied in a post-infectious arthritis. ABP wants you to know the specific pathogens associated with it, which include parvovirus, rubella, and hepatitis B. Management is observation, non-steroidal anti-inflammatories, and if it really looks like it's persisting and becoming chronic, specifically more than 6 weeks, you would need to refer to rheumatology for a chronic arthritis diagnosis or workup. Critical is that observation component because a lot of kids will just get better on their own. Moving on to reactive arthritis, which is a type of spondyloarthritis. Spondylo is vertebra. Arthritis is inflammation of the joint, and we'll go into that a little bit in more detail later, the different types of spondyloarthritis. But reactive arthritis is really an acute onset, occurs 1 to 4 weeks after a GI or GU infection. There's no viable pathogen within that synovial fluid, and listed are the commonly associated pathogens seen in reactive arthritis. ABP would like you to know about the different clinical presentations, which include, as I had mentioned, a GI or GU infection. Musculoskeletal findings will not only be arthritis, but can involve enthesitis, dactylitis, as well as potentially back pain. If back pain is involved, I would encourage you to order an HLA-B27 in the evaluation of a spondyloarthritis. Again, I'll discuss that a little bit more later. Extra-articular manifestations include ocular, GU, GI, oral lesions, and dermatitis. What do you do for these patients? Well, if it's clear there's a specific pathogen involved, such as chlamydia, you treat the infection. Otherwise, you're giving supportive care for the arthritis, including non-steroidal anti-inflammatory medications, rest, ice, compression elevation, heat. If the symptoms are lasting for quite a long time and the patient is experiencing a lot of pain or disability, I love using physical therapy to help with the management process. Steroids or disease-modifying anti-rheumatic drugs can be used, but those patients should have a chronic arthritis evaluation by a pediatric rheumatologist. So post-infectious reactive arthritis is typically short in duration, so less than 6 weeks, that's going to be that magical duration where if it's longer than 6 weeks, the child should really have a more thorough chronic arthritis evaluation. There's a clear infectious prodrome. Symptoms occur weeks later. And it's important to be able to differentiate between an active infection, meaning a septic arthritis, versus the post-infectious arthritis, which is this immune response to the infection. Now, moving on to juvenile idiopathic arthritis, which is the most common thing that I see in my clinic. Picture of a polyarthritis patient. As you can see, a lot of small joint disease. Just to get your brains moving a little bit, what is the most characteristic laboratory finding in a young child with oligo, articular juvenile idiopathic arthritis? Oligo is 4 or less joints, which you're going to learn in just a little bit. Would you anticipate an elevated ESR, anemia, elevated AST or ALT, a positive anti-nuclear antibody test, or low albumin? We'll get to the answer in a little bit. Here's the outline that ABP would like you to focus on when you're reviewing this information. What are the clinical findings, the lab findings, long-term complications? Are you able to formulate a differential diagnosis for a chronic arthritis? And then what is basic management as well as side effects of therapies? So juvenile idiopathic arthritis, formerly known as juvenile rheumatoid arthritis, so feel free to correct anyone who says JRA. It has been JIA for some time now. Let's start with a definition of arthritis. If you see a patient that has heat over the joint, and I oftentimes like to use the back of my hand and feel both joints. If there's heat and swelling, that's a sign that they have inflammation of the joint, and that equals arthritis. Also, if they have pain on range of motion, as well as a limitation on range of motion, that is also a definition of arthritis. So JIA technically occurs in patients that are less than 16 years of age. If they're 16 and older, then by definition, it is rheumatoid arthritis. As you've heard before, symptoms last for longer than 6 weeks and classically include morning stiffness, as well as gelling or stiffness after prolonged sitting, which patients describe after a long car ride or sitting in the classroom for a long time. What's always really important is that other autoimmune diseases are excluded, such as lupus, and we'll talk about that a little bit later. So we have some recent 2021 MOCA PEDS content specifications that I wanted to include and highlight. Specifically, recognize common causes of joint pain in children and adolescents. And we'll get to the arthritis mnemonic, which some of you are probably familiar with already. Arthritis, avascular necrosis, reactive, post-infectious arthritis, trauma, hematologic, such as sickle cell, rickets, or other metabolic problems, infection, tumor, idiopathic pain syndromes, as well as systemic rheumatologic problems like lupus or Kawasaki's disease. Just to note, these are the 5 different classifications of juvenile idiopathic arthritis. JIA is an umbrella term for these more specific diagnoses. ABP would like you to know more specifically about psoriatic arthritis, so they have a separate section on psoriatic arthritis, which I have included as well. Let's start with oligoarticular JIA. So the ABP would like you to know about the clinical findings within oligoarticular JIA. So this is a summary slide, and I'm going to highlight that labs are essentially normal in this population, except for a positive ANA, which occurs in up to 20 or 25% of all oligo patients. Rarely you'll see a rheumatoid factor. We do not see a profoundly elevated sedimentation rate or CRP. That should be a red flag for something else that's going on. Complications include uveitis or leg length discrepancy. And again, they would like you to know about the differential diagnosis when you have an individual coming into your clinic with 4 or fewer joints involved with arthritis. And that includes malignancy, infection, including post-infectious, IBD or celiac disease. This is an example of a complication of juvenile idiopathic arthritis. I'll just give you a moment to take a look at the picture. And as you can see that the left leg is longer. You can look at the more superior portion of the knee and see that that left side is a little bit on the lower side. And also his stance. So if you were to look at him from the posterior view, you see that there's a little bit of a pelvic tilt as well. Moving on to poly-JIA. As in oligo and poly, more females than males. There are 2 peaks. Poly means 5 or more joints. So that would include more of the small joints like the hands, PIPs, MCPs, MTPs. It's often symmetric. We can see lab abnormalities with poly-JIA, including rheumatoid factor and an ANA that's positive. Generally, polyarticular JIA is more destructive, more aggressive. So we can see bone erosions, cartilage damage, etc. What's the differential diagnosis between poly and, let's say, oligo? You'll see some similarities here. But in particular, we worry about some of the systemic rheumatologic diseases. More commonly, we see the polyarticular than the oligo with these systemic rheumatology problems. An example of what this PIP small joint arthritis looks like, very typical, symmetric. Moving on to systemic juvenile arthritis. As you can see here, it's essentially equal in terms of gender equity. Females equals males, typically less than 17. Otherwise, there is an entity called adult onset Still's disease. These patients not only have a polyarticular arthritis, but they also have systemic features. They have a quotidian fever, which means they have a pattern fever. When you ask a good history, then you're going to see that every night these patients have a fever. Middle of the day, nothing. Maybe they also wake up with a fever as well. And this is patterned for many days. With the fevers that come along rash, maybe worsening of the joint complaints, lymphadenopathy, which is the LAD, as well as hepatosplenomegaly, which is HSM. As you can imagine, there are significant lab abnormalities with systemic JIA. I'd like to highlight checking ferritin levels for these patients because one of the complications of systemic JIA is an entity called macrophage activation syndrome. I won't go into detail about MAS, but the morbidity of MAS is quite high. So we have to be aware of macrophage activation syndrome, and starting with checking a ferritin can be very helpful. As you can see here, they can have other areas of involvement, including a pericarditis. So what's the differential diagnosis of systemic? Well, it's definitely going to be your systemic rheumatology diseases, such as lupus. Infections, such as parvovirus, osteomyelitis, as well as malignancy. I wanted to include this slide just so you have an understanding of what we mean by salmon-colored rash. This tends to appear quite frequently on board exams. What's very important is that the rash in systemic JIA is migratory. If you see a persistent rash in someone you're evaluating for a fever of unknown origin, I would highly suggest that you look for alternative diagnoses. Systemic JIA really is migratory, the rash. So what are you going to do for these patients when they walk in your door? You're going to do an excellent history and physical exam. If you're going to check labs, I would recommend that you check some basic labs, looking to make sure that there's no elevation in the sedimentation rate, for example. If you have a child walking in with 1 or 2 joints involved, that's going to make you think about something different if that ESR is really elevated. I would check an ANA for reasons we'll discuss in a little bit. Rheumatoid factor in the older child, as well as anti-CCP antibody in the older child, as well as HLA-B27. If there's a concern about septic joint, you must get synovial fluid analysis, especially in the monoarticular disease. I would also say consider checking rheumatology serologies in patients who are an adolescent, Latina, African American, Asian American, as well as female. And we'll get into why specifically, but essentially we need to make sure the patient doesn't have lupus. X-rays are an excellent way to start, looking for erosions, effusions, as well as malignancies. So getting back to our question, what is the most characteristic laboratory finding in an oligo-JIA patient? It would be the ANA, not the ESR, as hopefully you have a better understanding at this point. Just to review, the JIA long-term complications includes leg length discrepancy as well as uveitis. The picture on the upper right demonstrates what's called posterior synechia. That is a complication of uncontrolled anterior uveitis. In JIA patients who have a positive ANA, that's high risk for the development of uveitis. So ANA positive, new diagnosis, young age at diagnosis, and female all purport a worse prognosis or a higher risk for the development of uveitis. They require frequent ophthalmology visits every 3 months for the first 4 years if they meet that criteria. Very important to see what their ANA status is at the beginning. So if you're the one who diagnoses oligo-JIA, then you can start with a referral to ophthalmology. Another complication is TMJ arthritis. With chronic TMJ arthritis, we can have micrognathia as seen in the growing child. This occurs in actually a majority of GIA patients, and it can be asymptomatic. So it's very important to check the TMJ joint for any clicking or cracking, as well as ask the family if they've noticed, and even check earlier pictures to determine if they've had appropriate mandibular growth. If there's a question, you get a TMJ MRI. Here's another complication called band keratopathy, a complication of uncontrolled uveitis. What do you do for these patients? Well, we're here to help you, pediatric rheumatology. But you can start off with some non-steroidal anti-inflammatories. I like using naproxen. It's a BID dosing. You can use 10 milligrams per kilogram. After NSAIDs, we'll start methotrexate, but really it's depending on the type of GIA that's involved. For the more involved individuals, we will use methotrexate as well as potentially one of the biologics at the onset. We often use intra-articular corticosteroids. We try to avoid the systemic steroids as much as possible, especially in light of the development of all of these really wonderful biologics. Biologics specifically including targeted treatment, targeting the pro-inflammatory cytokines as listed, tumor necrosis factor, interleukin-1, interleukin-6, as well as CTLA-4, which blocks the co-stimulatory signal for the activation of T cells. In addition to medications, there's supportive care with heat, as well as physical therapy, occupational therapy, and resting night splints. It's very critical to getting their range of motion back. ABP would like you to be familiar with some of the basic side effects of juvenile arthritis medications, including gastritis, as you know, with NSAIDs. Methotrexate, we have to be aware of transaminitis, leukopenia, mucositis, and nausea. Methotrexate dosing is typically 10 to 15 milligrams per meter square, as opposed to oncology dosing, which can be 200 to 250 milligrams per meter squares. Now, side effects will be quite different because of the differences in the dosing. So I really reiterate the difference in dosing, therefore the difference in potential side effects for our patients. Steroid injections are typically well tolerated. Oftentimes we do have to use sedation for our little patients, and can include infection, obviously, with any injection. More commonly, however, less than 5% is fat atrophy as well as skin hypopigmentation. And one important infection to be aware of when starting biologics is tuberculosis, specifically for the tumor necrosis factor inhibitors. And of course, this list is not exhaustive. Let's move on to psoriatic arthritis. I think pictures are so terribly important in memory. So you're going to see a lot of pictures from me, including onychomycosis, as seen here very typically in psoriatic arthritis, as well as dactylitis or sausage digit. seen in psoriatic arthritis. So this is a specific JIA subtype. The differences between, let's say, an oligo and a psoriatic arthritis is definitely going to be the psoriasis, but also we're going to see there's more oftentimes small joints involved, even though there's just a few. It can't be asymmetric, and then of course you're going to be looking at the nails. Differences between psoriatic arthritis and oligo or poly include psoriatic arthritis will have a higher rate of sacroiliitis, as well as a higher rate of enthesitis. And just to remind you, an enthesis is the connective tissue between the tendon or ligament and bone. So it's inflammation within that connection. Pictures of clinically what dactylitis looks like in that left fifth digit. And then on MRI, it's really quite clearly a tenosynovitis of the digit, as well as extension into the wrist and those extensor tendons. So another high yield slide for JIA. ANA equals risk for uveitis. Nail pets, think psoriasis. Complications include uveitis, TMJ arthritis, as well as leg length discrepancy. Red flags for oligo JIA include an elevated inflammatory markers, as well as severe pain. These kids do not have severe pain in oligoarthritis, including even the polyarthritis, but really oligoarthritis, they should not have severe pain. Limp, we want you to evaluate the joint above and below, as well as look for systemic features. Let's move on to inherited disorders of connective tissues. ABP would like you to be familiar with Marfan syndrome, clinical as well as lab findings, as well as hypermobility syndromes. So Marfan syndrome, as you can see, the arachnodactyly evident on the top picture. Picture A demonstrates the thumb sign, as well as B, the wrist sign seen in Marfan syndrome. And if you were trying to remember what the genetic mutation is, it's a good thing to remember. This is a good reminder. FBN1, ABP likes to test on this one. This is autosomal dominant. However, 25% of Marfan syndromes are de novo. It is characterized as a systemic connective tissue disease. Essentially, those links are not as tight as they should be. Therefore, you have manifestations in wherever you see fibrillin. And that includes ocular, cardiac, and musculoskeletal. These patients are tall, arm span greater than height. They have the arachnodactyly, as seen in the previous slide, and they have variable associations with a high arched palate, pectus carinatum, or excavatum. They can have joint hypermobility, although not always. Specifically, the eye abnormality is ectopia lentis, upward dislocation of the lens, which is the opposite seen in homocystinuria, as well as a third have cardiac involvement. Always good to check an echo if there's any concern about Marfan's, if you're waiting to get authorization for the genetic testing or sending to genetics. Benign hypermobility syndrome is so common in my clinic in terms of a reason for arthralgias in the pediatric population. So on clinical exam, they're going to be generalized, have generalized hypermobility. On history, you're going to hear that they have pain during or after activity, as opposed to morning stiffness, which is described in your chronic inflammatory arthropathies such as JIA. Management is going to include a lot of education. This is how their body is. They might have a family member that has something that has similar findings. It's going to include education, non-steroidal anti-inflammatory medications, as well as physical therapy, a lot of physical therapy, and sometimes for a lifetime. What's really important is that they do the home program regularly in order to get great benefit from the physical therapy. Ehlers-Danlos, I'm just going to briefly mention here, there are multiple types. And specifically, the mutation is in the COL gene involving collagen production. But what I want you to know more specifically is how can you differentiate between a benign hypermobility syndrome and EDS? Well, if you see other signs on a good physical exam, including a good skin exam, is the skin thin, hyperelastic? Do you notice cigarette paper scars, or is there a history of easy bruising, and not just in the anterior tibial area where all kids seem to have bruising? Are the joints, when you get a history, have they had multiple dislocations? Cardiovascular, if you're suspecting a genetic syndrome such as EDS, get that echo. Look for mitral valve prolapse, as well as obviously an aneurysm or early signs. So another high yield slide for you. Marfan's versus EDS. Similarities, as noted. What are the differences? So those differences noted are specific to Marfan syndrome. So Marfan's has the specific gene mutations. Marfan's has disproportionate tall stature compared to EDS. Typically, Marfan's has normal skin, even though you can have some striae in the back with that growth. Marfan's has lens dislocation, pectus carinatum, as well as progressive aortic changes. Now moving on to lupus. This is a big one. So here is what is required by the ABP. Again, I will be highlighting throughout the lupus section, making sure every single one of these light items is addressed. You all remember this from medical school, SOAP brain MD. Well, this is really a good way to think about how systemic lupus is. There are different types of lupus, but we're just talking about the systemic lupus erythematosus. We see a lot of pediatric lupus, and it really is occurring within the African American, Latino, and Asian populations more predominantly than the Caucasian population. Females definitely overrepresent this cohort of patients. Typical findings include hematologic. I'll go into detail for each one of these symptoms in subsequent slides. Mucocutaneous, musculoskeletal, fever, renal, nonspecific abdominal complaints, as well as just fatigue or malaise. And I'll oftentimes hear about changes in their school abilities or participation, possibly suggesting some cognitive dysfunction as well. ABP would like you to know about, well, what would be some of the atypical or less common findings? Well, compared to adult lupus, adults have Sicca syndrome more commonly. That's the dry eyes, dry mouth, seen in Sjogren's syndrome. More typically in adults, they have Raynaud's, even though in pediatric population, they have that as well. There's a lot more stroke or dementia in the adult population compared to the pediatric population. I'm going to run through each of these organ-specific slides a little quickly, but I wanted to include them for your reference at a later time. These are how lupus criteria defines abnormalities within the heme system. Within the mucocutaneous, which can involve the malar rash with the nasolabial fold sparing. Oral or nasal ulcers often can be painless. You can derive a history of sun sensitivity. So if someone goes out to the beach, they're the ones that get a horrible sunburn compared to maybe their sibling. Raynaud's phenomenon, discoid lesions can occur more common in adult population. But I'm going to show you here a teenage male with scarring alopecia, as well as a scarring discoid lupus. Rash seen in a young lupus patient, typical of a vasculitic rash that we can see in our systemic lupus patients. Periungual vasculitis, interarticular dermatitis seen in lupus. And I would just want to highlight the nail bed capillary abnormalities. Look how hyperemic those nail beds are. That suggests a small vessel vasculitis seen in lupus, as well as can be seen in juvenile dermatomyositis. Raynaud's phenomenon. Musculoskeletal findings, polyarthritis. As you've learned about JIA, it's really important to think about systemic diseases in a young female with polyarticular disease. They deserve a juvenile arthritis workup as well as a lupus workup as well. They can have neuropsychiatric findings. Most commonly, it's headache. But if you ask adolescent females, majority of them have headaches that are not necessarily related to lupus. This can be a difficult one to pinpoint and attribute to lupus specifically. Renal findings are the most important things to be looking out for our patients. Majority will involve some type of kidney disease. There's higher rates of nephritis in the pediatric onset lupus compared to adult onset lupus. Diffuse proliferative glomerulonephritis is the most common type of lupus nephritis, and symptoms include proteinuria, hematuria, hypertension, pedal edema, and of course, progressively acute renal failure. These patients can have a serositis, which includes a pleuritis, as well as a pericarditis. Gastrointestinal symptoms, we will often see a hepatitis, not necessarily autoimmune hepatitis, but an elevation in the AST and ALT that improves with initial treatment. Hypo or hyperthyroidism can present as well at the onset. So when do you order these autoantibodies, the elusive autoantibodies? When do you order the double-stranded DNA, ANA? What does this mean? Well, the ANA in the new criteria has to be positive. And the new adult criteria, an ANA is required, as well as some of the other serologies as listed here. An anti-double-stranded DNA is very specific to lupus nephritis. Anti-Smith is specific for lupus. If you see anemia, maybe check a Coombs, see if that's positive, as suggestive of an autoantibody against those red blood cells. Antiphospholipid antibodies, such as lupus anticoagulant, beta-2 glycoprotein, or cardiolipin antibody, are important in the initial evaluation and can help a patient meet criteria. We're always here for you in pediatric rheumatology, so don't feel you have to know all of these serologies specifically. You're going to order some basic tests. CBC, never forget that urinalysis because we do worry about renal involvement. Low complement is suggestive of kidney disease. Other studies include an echocardiogram looking for serositis, plus minus x-rays or MRI of the brain, just depending on how they're presenting. We do recommend an ophthalmology consultation as baseline for the initiation of hydroxychloroquine, which is standard of care for all of our lupus patients. How do you treat these patients? Initially, if there's no renal function, we'll start with naproxen if there's a lot of arthritis or arthralgias. Oftentimes, these patients do require steroids. Majority of patients do require steroids and long-term steroids. Hydroxychloroquine, we call that our lupus vitamin. Every patient with lupus requires hydroxychloroquine. Depending on the organ systems involved, they may require methotrexate for their arthritis. Renal disease, it depends on what the pathology shows. Every lupus patient that develops proteinuria requires a kidney biopsy, so we work very closely with our nephrology colleagues. And listed below is Benlysta, or belimumab, which is a new medication approved for lupus. So what's the prognosis and complications of these patients? Well, it's more severe in children. Morbidity and mortality is higher because of that renal disease involvement. There are oftentimes drug-related complications, specifically infections. As you can imagine, we're using a lot of immunosuppression medications. The most common side effect of chronic immunosuppression is going to be infection. Chronic steroid use includes osteoporosis, hypertension, AVN, growth disturbances, gastritis, cataracts, and diabetes. And again, here's that macrophage activation syndrome, which I mentioned within the context of systemic juvenile idiopathic arthritis, but can involve and can present along with a new diagnosis of lupus. So here's your high yield slide for lupus. Multi-system disease in a teenage female, but it can involve males as well, just more predominantly in the females. High-risk ethnic group. Complications, we really worry about our lupus nephritis specifically, as well as medication side effects. So I was asked to talk about the new 2021 content specification specific to long-term corticosteroid therapy, given that our lupus patients do require long-term corticosteroid therapy. So as you know, chronic steroids suppress the HPA axis, which leads to adrenal atrophy and loss of the cortisol secretory capabilities. The HPA axis suppression is dose-dependent and duration-dependent. So what happens when these lupus patients who are on chronic steroids are injured, have a trauma, require surgery? They're unable to produce the compensatory cortisol response because of the HPA axis suppression. So it's important to educate families about stress dosing. And I've listed if the patient is otherwise okay, they can tolerate the oral stress dosing. Dosing is listed. If they're more critically ill or moderately ill, IV dosing as listed. Moving on to dermatomyositis. ABP apparently really wants you to know about dermatomyositis. They included in the AB content specifications as well as the 2021 MOCA PEDS content specifications. What's important to know is that this is an example of a vasculitis, a small vessel vasculitis, involving primarily the skin and the muscle, but it's a systemic disease and can involve other organs as well. Females, again, predominate, but not to that degree as seen in lupus and the oligo or poly-GAA. What's the criteria to meet to earn this diagnosis? Well, you need to have symmetric and proximal muscle weakness. Very important, the proximal muscle weakness. Be familiar with the Gowers maneuver, having a child sit on the ground and see how they're able to elevate again. Be familiar with the cutaneous changes seen. I have some additional pictures coming up. The classic heliotropic rash, which involves discoloration of the eyelids and even periorbital edema, as well as the Gautrons papule, which I have a nice picture following here. The heliotropic rash essentially reveals this purplish rash. You see the nasolabial fold involvement, quite diffuse, periorbital edema as well in this young female, as well as the classic Gautrons papules involving the MCPs and PIPs. And if you look really closely on that picture to the right, you'll see that the nail bed capillaries also have some hyperemia as well, suggesting, again, consistent with a small vessel vasculitis. Which labs do you need to check for these patients? So again, besides an excellent history and physical exam, you're going to be checking some labs to look for elevations in muscle enzymes, specifically AST, ALT, LDH, and specific to muscle enzymes is the aldolase. Total CK. If you're unclear about the diagnosis, obviously you're going to be sending to us in pediatric rheumatology. We will oftentimes now just order an MRI. And if the patient is classic enough for JDM, we can avoid the muscle biopsy. EMG is not currently being utilized for the diagnosis of JDM. This should be reserved for those patients that are presenting atypically. So what else are you thinking about if you have an individual with symptoms of a myopathy? Non-inflammatory myopathy includes the different muscular dystrophies, as well as metabolic diseases. You should also include in the differential diagnosis infections or other autoimmune diseases. Infections specifically Coxsackie, autoimmune disease, scleroderma, lupus. MCTD is mixed connective tissue disease, which is essentially the cousin of lupus. SJIA is systemic juvenile idiopathic arthritis. Foundation of treatment for JDM patients are steroids. So we have to really monitor these patients for all the side effects discussed because kids will be on steroids for over a year. We also use methotrexate, IVIG, as well as hydroxychloroquine. This is an example of how clear the myositis appears in a patient with JDM. Moving on to sarcoidosis. ABP would like you to be familiar with the clinical findings associated with the disease. I like to think of it as a triad: polyarthritis, dermatitis, and always consideration of uveitis, which initially can be asymptomatic. By definition, you need this is a pathologic diagnosis essentially, which you would see non-caseating epithelioid giant cells. There is a familial version of pediatric sarcoidosis called Blau's syndrome, and there are specific genetic mutations seen. Labs for sarcoidosis patients include elevated acute phase reactants, mild anemia from anemia of chronic disease. Oftentimes, the ACE is normal in our pediatric population because oftentimes they do not have pulmonary involvement like we see in the adult counterparts. Treatment is corticosteroids, methotrexate, as well as TNF inhibitors. Hopefully someday when we give this lecture in the future, we won't have to include corticosteroids so often for the treatment of so many of our systemic autoimmune diseases. It's a wonderful medication, but as you all know, it has tremendous side effects, including interruption of growth potential. Moving on to ankylosing spondylitis. This is what the APP would like you to know about ankylosing spondylitis, as well as arthritis of inflammatory bowel disease. Juvenile ankylosing spondylitis is an example of a spondyloarthritis. Spondyloarthritis is the umbrella term, and juvenile ankylosing spondylitis is a more specific example of a spondyloarthritis. So this involves the chronic arthritis of the axial and peripheral skeleton. So by definition, you have axial involvement. Again, spondylo means vertebra. So axial involvement, as well as you can have peripheral involvement. It is well characterized by the presence of enthesitis or inflammation of the entheses, arthritis. Patients will complain of morning joint stiffness or back stiffness, where they get up and they feel really stiff, unable to move, and this is clearly an observation made by the family members as well. You might get a history of nighttime back pain, where patients have gone through maybe 3 or 4 different mattresses because they're unable to get comfortable. That's a classic sign of an inflammatory back disease. Which labs did you get for these patients? Really important is that B27, HLA-B27. This is present in about 90% of all patients with ankylosing spondylitis. Not 100%, but a high number. They're typically seronegative, meaning negative ANA, as well as a negative rheumatoid factor, signaling this is not an autoantibody process, rather something similar. Imaging should start off with an X-ray of those SI joints. It's important to get the 3 views because the SI joints are at a curve. So order those 3-view SI joints. If it shows sclerosis on the X-rays, I would highly suggest you get an MRI of the pelvis to include the sacroiliac joints as well. You can have some findings of osteitis in a healthy, athletic, young individual. So it's important to review the MRI of the sacrum with an expert in musculoskeletal disease. Here is an imaging of the sacroiliac joint. As you can see here, the osteitis, as well as sclerosis. And I really love this picture because it reminds me of Casper the Ghost. Moving on to another type of spondyloarthritis. Again, spondyloarthritis being the umbrella term, arthritis of inflammatory bowel disease. And the ABP just wants you to be familiar that patients with Crohn's disease, especially more so than ulcerative colitis, can have a chronic arthritis and specifically an axial arthritis. So if you're taking care as a primary care physician, an individual with Crohn's disease, they start complaining of chronic pain in the peripheral joints or the lower back. Think about spondyloarthritis in this patient, order an X-ray, order that HLA-B27, and send over to us in pediatric rheumatology. Your high yield slide for juvenile ankylosing spondylitis is that HLA-B27, and hopefully you're more comfortable with knowing when to order it. There is an association with IBD. So even in my patients with ankylosing spondylitis, I'm continually observing them and monitoring them for the development of inflammatory bowel disease. Classically, the back pain includes morning stiffness and night pain. They can have enthesitis of the patella, of the Achilles is quite common. And this is the one disease where males outnumber females. In a previous content specification, they had wanted you to know about differential diagnosis of back pain. So I included that list for you. Moving on to fibromyalgia. Fibromyalgia is not an autoimmune disease. It is a disorder of pain dysregulation, so this could be discussed in neurology. We do see them in the pediatric rheumatology clinic because pediatricians are unclear if this is secondary to a chronic inflammatory process or if it's a pain amplification syndrome. But again, this is not an autoimmune disease. Mean onset is during the adolescent period. Females far outnumber males. Clinical symptoms are quite diffuse and include chronic widespread pain, headaches, depression, fatigue with quite classically sleep disturbances, so history of non-restorative sleep, sleeping 12 hours but waking up and feeling like they didn't sleep an hour, irritable bowel syndrome, as well as foggy brain. We can see secondary fibromyalgia in some of our primary autoimmune disease patients. And lastly, let's move on to rheumatic fever. As most of you are familiar with, the Jones criteria. I've listed here the major criteria on the left and the minor criteria on the right. Major criteria includes carditis, seen in the majority of patients, 50 to 70%, migratory arthritis, subcutaneous nodules. So to meet criteria, you need evidence of strep, as well as 2 major criteria, or evidence of strep plus 1 major and 2 minor criteria. So moving to the middle of the slide, what does that mean, evidence of strep? So you should have a positive throat culture, rapid strep antigen test positive, or an elevated or rising ASO or DNAsB. It's important to know what your population risk is. That helps determine how conservative you are when you're using the Jones criteria. When there is a rheumatic heart disease prevalence of less than 1 to 1,000, that's considered low risk disease, low risk population. Typically, acute rheumatic fever develops 2 to 3 weeks after group A strep infection. What are the exceptions to the Jones criteria where you don't need that strep plus 2 major? It's when there's chorea present, when there's an indolent carditis present, or if you have recurrent ARF in patients with a history of ARF-associated carditis or rheumatic heart disease. And here I've listed the definition for a moderate or high risk population. And then you're going to use a slightly modified Jones criteria. Again, being conservative in terms of treating in a timely fashion in order to avoid chronic problems within the heart. I just wanted to mention the pancarditis because ARF is the most common cause of acquired valvular disease in the world. This is a preventable disease. So important to consider, as well as important to convey to our international colleagues and see how we can do to help. What's the treatment? It's still penicillin, intramuscular or oral. If there is a lot of arthritis symptoms, you can give naproxen. And if they have progressed to heart failure, then we're involving our cardiology colleagues to help us with management. When do we have to consider secondary prevention? Well, it depends on if there is cardiac involvement. If there's persistent valvular disease, then they require secondary prevention, so penicillin G IM every 28 days for 10 years or until they're about 40, whichever's longer. No valvular disease for 10 years or until they're 21, whichever is longer. No carditis, meaning acute rheumatic fever only. Then they require secondary prevention for 5 years or until they're age 21. ABP would like you to be familiar with the differences between lupus and acute rheumatic fever. In lupus, we're going to see these autoantibodies. So again, I want you to think about what is that pretest probability that an individual has lupus so that you can order those autoantibodies and feel confident that if it's positive, it means something. If you order an ANA and you're not confident that there is a systemic rheumatology problem, the ANA is positive in up to 20% of the healthy population. That's not very helpful if you don't have a high pretest probability. Other differentiating features for lupus is a photosensitive rash. In acute rheumatic fever, you won't have that. The arthritis is not migratory, it's persistent in lupus compared to acute rheumatic fever. And in lupus, females predominate over males. The board review committee wanted me to discuss how to evaluate and manage a child with unexplained fever as recommended by the 2021 MOCA PEDS content specifications. This can be a complicated issue and question. So if this is a fever of unknown origin case, you're going to have multiple consultations involved to help determine what the etiology is. Fever is defined by greater than 38.3 degrees Celsius, at least daily, for 8 or more days. The most common causes are really infectious in the pediatric population, and then rheumatologic, then neoplastic. How do you evaluate these patients? A really good history. What are the patterns of the fever? Is there a pattern to the fever? Or is it all day and persistent? What were the exposures that the individual had? Did they have sick contacts? Were there animal exposures, insect exposures, travel, recent or new medications? When you examine the child while febrile, doing a good dermatologic exam, scalp, ocular, looking for sinusitis or pharyngeal exam, making sure there's no respiratory infections, abdominal exam, GU, and of course, musculoskeletal. You're talking to the rheumatologist here. Labs could include a complete blood count, peripheral blood smear, acute phase reactants, cultures, urinalysis, and don't forget that ferritin, looking for macrophage activation syndrome, possibly being associated with a systemic juvenile idiopathic arthritis. Depending on travel, looking for tuberculosis, and looking for, again, multi-system organ involvement by checking a complete metabolic panel. If they're looking otherwise well, except for the fever, you're going to be observing and seeing how long this fever will last. If you're able to, you're going to avoid steroids. Steroids, when given without a precise diagnosis, is dangerous because you might partially treat a malignancy. Attempting to avoid broad-spectrum antimicrobials as best as you can is preferred. Obviously, if the patient has risk factors such as tuberculosis or malaria, you're going to be treating with those specific antimicrobials. But again, the key is observation for as long as you can, because a lot of times these FUO patients will just resolve. And it's terribly frustrating as we don't know why they have that fever. In rheumatology, we will often do a non-steroidal anti-inflammatory trial. In our patients with systemic juvenile idiopathic arthritis, sometimes they start off as an FUO, and then later on they develop an arthritis. The naproxen trial can sometimes make a big difference. This is a team approach with the hospitalist or a general pediatrician if this is outpatient, infectious disease, rheumatology, as well as oncology. I've included some additional slides to help support your studying and knowledge about pediatric rheumatology. Thank you so much for your attention today. That was a whirlwind tour of pediatric rheumatology. Good luck on your boards.